I'm seeing it being recorded. Continue. Okay. The Carl Gay Weiler Great Decisions of 2021. And I don't know how many years Great Decisions has been doing this with the Indiana Council of World Affairs. Those of us on the committee have just been with us for a few years, but our commitment is to bring very exciting speakers to the programs that are presented to us by the Foreign Policy Association. And it's called now the Carl Gay Weiler Great Decisions because many of you will recall that Carl Gay Weiler, who was a longstanding member of and on the board of directors and served as president, I think certainly at least once, maybe twice, of the Indiana Council of World Affairs, died last year. He was very beloved and we missed him very much. We thought the greatest way to honor him was to name this series that he worked so very hard for to make it successful. And of course, around the state in his name. I'm going to introduce to you Claire Collins. Members of the committee include Claire Collins. If you'll just raise your hand, Claire, so they know who you are. Diane Helmkamp Farrell. Diane, if you are somewhere in one of these four pages on the room somewhere. Ray Montagno, if you are somewhere near me and you can rate. And then our technical host this evening is Adebola Ogundibe. Now, she will be responsible for, if you are muted, unmuting you, please, if you could just unmute yourself when it comes time for you to ask a question, if that's what you'd like to do. Stay muted. Otherwise, we'd like to be able to give you that responsibility. We don't want to feel like we're policing that. We've never had this problem, but I will just alert you that if there is a disruption, what have you, then our technical host will be handling that. Claire Collins will be introducing our speaker this evening, and Ray will be handling the questions of the Q&A period for the veterans. Our speaker will present about 40 or 45 minutes, and then we have a very robust Q&A. For those of you who are new, one of the things we pride ourselves with is having a very robust Q&A, and we welcome that. And then we'll tell you about future programs that will be coming on board. And so with that, I am now going to bring on Claire Collins to introduce our speaker.
Hi, our speaker tonight is Dr. Adrian Gardner. He was educated at Brown University and Harvard Medical School and has been interested in TB, HIV, and other infectious diseases in underserved communities since his time at a clinic in Rhode Island all the way to Kenya. He traveled to Kenya as a medical student in 2001, where he first became acquainted with AMPATH, which stands for Academic Model Providing Access to Healthcare. He spent 7 years working in Kenya and joined Indiana University in 2012 as the field director for AMPATH in Eldoret, Kenya. He was appointed director of the IU Center for Global Health in February of last year. And at IU, he is also Associate Dean for Global Health, the Donald D. Brown Scholar in Global Health, and Associate Professor of Clinical Medicine. And he has cared for patients at Eskenazi Hospital. Welcome, Dr. Gardner.
Thank you very much. Share my slides here. Can everybody see that okay?
Yeah.
Great. Well, thank you so much for the opportunity to be here tonight and to tell you a little bit about the work that we do in Kenya and how it's adapted itself a bit to the global pandemic that we all are living with. So I really appreciate the invitation and look forward to discussing more with you. So I'm going to try and accomplish a few different things tonight. I'm going to try to start with just sort of a current status of the pandemic, kind of put us all in the context. I know it's hard to get away from the news of it, so everybody sort of keeps up with it, but just to give us some common ground to start with. I'll tell you a little bit about the Indiana University Center for Global Health and the AMPATH partnership, which is one of our flagship programs. And then really the impact of the pandemic and how we've adapted to that. And then sort of conclude with, I think, some reflections on sort of challenges and opportunities for the global health community ahead of us. So again, many of us are used to seeing all these charts and graphs and world maps. And as of this morning, we are over 103 million documented cases globally and over 2.2 million deaths. And And, so I think it's obviously fair to say we're in the middle of the worst global public health crisis in over 100 years, for sure. So these are strange times. In the United States, we've had really at least sort of 3 surges, if you will. And you can see that we're in our third surge now. We're actually kind of on the downslope of it. But you can see that the steepness of the curve has sort of increased, particularly in this third surge, increased much more steeply, and the daily caseload has gone much higher than it did in the previous ones. This was a similar pattern than we saw in the the pandemics of the early 1900s, where this sort of second or third surge was sort of a much deeper impact. So in the United States, we now have over 26 million cases documented, and I think we're about 445,000 deaths as of today. How are we doing in Indiana? Well, kind of similar. We are number of daily cases and number of hospitalized patients has actually sort of peaked and is on its way down, fortunately. So things are definitely on improving, but we've had obviously this pretty massive spike as sort of a second or third surge here in Indiana as well. So in Indiana, we've had over 600,000 documented cases, and we're just shy, I think, of 10,000 deaths from COVID since the beginning of the pandemic. So that's kind of the latest in epidemiology. Of course, we all know that we are have very rapidly developed vaccines against this infection. And this is a bit of a vaccine timeline. And I think, as many of you know, there are 2 vaccines currently that are approved in the United States. So this Pfizer-BioNTech one and the Moderna one. Those are both messenger RNA vaccines. And you can see that the AstraZeneca one has been approved in some countries in the world, many countries in the world actually, but not yet in the United States. And then there are several still in development that we're awaiting data any day now. So the Novavax, Johnson & Johnson have released a little bit of data, but we expect them to, at least Johnson & Johnson will probably apply for a approval or look at least an authorization to use it in the next week or 2. There are also, incidentally, 4 vaccines that Russia and China have developed and actually started using before conducting large clinical trials. So those are also out there just and being used in other parts of the world. So how are we doing on vaccines in the United States? Well, we've distributed close to 50 million doses and administered about 32 million of those doses. So we have at least 26 million people that have received 1 dose and close to 6 million now that have completed their vaccination. And as you all know, the CDC recommended, well, each state was kind of left to their own discretion to sort of determine which groups were prioritized for vaccine, but many of the states chose to vaccinate healthcare workers. And then in the state of Indiana, we've really been going down by age group, which is a reflection of the highest risks of morbidity and mortality from this infection. So in terms of global vaccine rollout, so the US has actually administered more doses than any other country in the world. We're at 33 million out of a total 104 million doses globally administered. And we're, I think, 4th or 5th on the list of sort of doses per 100 people. So you can see that the Seychelles and Israel are really kind of leading the way. I think Israel's over 30 or 40% of their country is now vaccinated. So we've done the most, but still have a long way to go. And obviously, globally, much of the world has no access to vaccine currently, and that's a sort of massive global health problem, if you will, that we need to address. So that's kind of briefly on the epidemiology. I'm going to, I guess the only other thing I would say is we're sort of in a race against the variants. You guys have probably heard a little bit about some of these variants. So when viruses like this are constantly copying themselves, reproducing, they mutate as they do that. And so large amounts of infection lead to large numbers of mutations. And there's been a lot of news recently about these variants, that some of them are more easily transmitted, leading to more cases and more deaths ultimately. And there's some concern that some of them are actually of greater virulence. So they actually have a higher risk of morbidity and mortality associated with the infection. And of course, the big concern is that they may escape either natural or vaccine-induced immunity. And we've seen a little bit of evidence, particularly with the Novavax vaccine, where the trial that was conducted in the United States and a trial that was conducted in South Africa had actually pretty significantly different efficacies. And in part, the dominant strain in South Africa is thought to be one that might escape the vaccine-induced immunity, at least for that vaccine. It looks like the mRNA vaccines are holding up pretty well so far, but already Pfizer and Moderna are working on booster shots that account for some of the variants that are already being seen. I think it's important to keep in mind that many mutations come with a fitness cost. So not all mutations are necessarily a bad thing. In fact, many of the previous coronavirus epidemics that we had, the SARS epidemics of the past, actually kind of burned themselves out, presumably because they developed mutations that made them less fit. And so the virus kind of was less easily transmitted and ultimately burned its way out. Okay, so that's kind of where we stand with the pandemic now. So let me switch gears a little bit and tell you a little bit about global health at Indiana University. IU's global health efforts span over 20 countries and obviously engage many schools and many disciplines. And the Center for Global Health is a university-wide center whose mission is really to develop mutually beneficial partnerships across these various disciplines and schools and countries for the primary purpose of creating and implementing sustainable programs that improve health and human flourishing in underserved areas worldwide. And of course, we have an educational mission, preparing a critical mass of health education and health research experts in these communities, really to produce the next generation of national and global health leaders. So we really have a local and international focus on health inequalities. And one of our flagship programs, as was already mentioned, is the academic model providing access to healthcare. So this is a partnership between Moi Teaching and Referral Hospital, which is one of 2 national referral hospitals in Western Kenya, Moi University, which is a university based in Western Kenya and was the second medical school in Kenya, and a group of currently North American institutions, but may expand beyond that, that are led by Indiana University, but there are a dozen schools within the AMPATH Consortium that are kind of the North American partners to these Kenyan institutions. And this is a longstanding partnership, dates all the way back to 1988, when Moi University really first started its medical school. It was the second medical school in Kenya, as I said. So the tenets of this program, if you will, are that, to partner in the delivery of health services and strengthen public health sector systems so that it's a health delivery organization, strengthening and developing human capacity through training and education. So obviously we have an educational mission, advancing research to improve the health of underserved populations, and ultimately improving access to high quality medical care and reduce health disparities. So it's really kind of an academic model that has sort of the tripartite mission of academia, which is care or service, education, and research. So where do we work? We work in, well, as you all know, the Kenya is situated in East Africa here. And the catchment area that we serve is really this sort of western half of Kenya. And you can see these are counties that are highlighted in blue. Kenya, a few years ago, created a system of devolution. And each county is similar to kind of a state in the United States. So each one has a governor and a minister of health and a parliament. And so AMPATH works in 10 or 12 counties in the western half of the country. And the National Referral Hospital really serves the entire western half of the country with referral level care. So to try and summarize AMPATH's 33-year partnership in one slide, which is not very easy to do, I'll just give you again a sense of the tripartite mission and how we work across that spectrum. So in terms of care, we really believe in a holistic, sustainable approach focused on facility and community-based care and certainly inclusive of the social determinants of health. We've made many investments in infrastructure at the hospital and the medical school there. We serve a catchment of over 20 million people, and there are partnerships across over 27 disciplines and different counterpart relationships. So all of our faculty, for example, at Indiana University or one of our other consortium partners work in counterpart relationships with our Kenyan colleagues, helping to support them and ultimately the Kenyan leading the way. So just a few of the sort of highlights of the CARE program. We now have 170,000 people living with HIV that we care for in over 800 facilities within that catchment area that I described to you. Over 34,000 with non-communicable diseases. We have robust programs in maternal and neonatal child health and child life within the hospital. And a big focus in the recent years on cancer care, all the way from community screening, all the way up to sort of expert surgery, chemotherapy, and as of very recently, radiation therapy. On the training side, we have a commitment to bilateral faculty and trainee medical exchange. So not only do the North American institutions in the consortium send trainees, medical students, and residents over to Kenya, but they also sponsor Kenyan medical students to come and do rotations in their institutions. We provide a number of scholarships for Kenyan medical students, and we do all kinds of training in various disciplines. So clinical training, research training, medical, dentistry, nursing, public health, agriculture and engineering. We have formal degree programs and sometimes more certificate or diploma programs. Overall, if we just look at some of the sort of the metrics, if you will, of the program over the last 33 years, we've had more than 340 Kenyan trainees hosted in North America. Over 1,900 North American trainees have participated in the Kenya rotation. Most of them do a sort of a 1 to 2 month clinical rotation. We've had, as I said, over 30 years of North American faculty presence on the ground. We've started more than 10 new residency and fellowship programs. And when I say we, I mean really we, the collective we, with our Kenyan counterparts, because it really is Kenyans that are running and leading this program. It's really just in partnership with us. And on the research side, again, we've focused on relevant implementation science that informs local, national, international policy that can be applied. And we communicate those results to the various health policy makers. We have a multidisciplinary health systems approach. We've developed and supported a bunch of research infrastructure over the years, and we really sort of strive for equity in the partnership, recognizing that institutions are not equal, but the principle of equity is sought. So again, if you look at the metrics, highly successful program on sort of all fronts, over $169 million of cumulative research funding. About 80% of that has been from the National Institute of Health. Over 800 publications have come out of this partnership, and there are more than 70 active projects right now in the research program. Okay, so get back to this. These are challenging times for global health. We have stressed health systems in much of the world. The pandemic has forced the closure of educational institutions and obviously disrupted the global economy, shut down or forced the redirection of research. We've had obviously very restricted travel for faculty and trainees, essentially none. And there've been, institutional budget cuts across the board. And because global health is one of those things that people can't travel for, it gets usually appears high on the list of potential budget cuts. Right? But I would also, point out, but that I think that, it's also true that it has never been more true that the interconnectedness of the global community is sort of so obvious, right? That, there's nothing like a global pandemic to bring us together, so to speak. So I think while it's been a challenging time, I think it's ever more important that we recognize the importance and the connectedness that we all share as a global community. So what have we done to adjust to this? Well, really, I would characterize our efforts as strengthening health systems. And I'm going to talk a little bit about some of that remote support for our Kenyan colleagues, both COVID-19 response specifically, and also supporting ongoing service delivery, education, and research, some of the core program that we had in place. And we've also had an opportunity to apply our global experiences to local COVID response in Indiana. So I'm going to talk a little bit about that effort as well. All right, so let's move to Kenya. Kenya was sort of fairly late, or East Africa in general was fairly late to the COVID game. So the first cases were identified not until March of 2020. And you can see that, the slope of the curve was pretty flat in the beginning. And interestingly, the first COVID patients were identified among truck drivers, which was the same way that the HIV virus spread across the country and ultimately across East Africa, because those were people that were traveling and, on the road the whole time. And so they were interacting with people along the way. Again, Kenya kind of shut down pretty quickly. But as much of the world did, they sort of tired and depended on tourism. And so they reopened international flights August 1st. And you can see sort of a first bump in the road here. And then by mid-October, again, people were tiring of restrictions and they opened things up again. And you can see sort of just a dramatic change in the curve, the steepness of the curve, or the slope of the curve. And I should say that it has come down a little bit now. They're in a bit of a lull, just as we are. But in total, only 100,000 documented cases and only 1,750 deaths in Kenya. Now, obviously, some of that is underdiagnosis and underreporting. But it's interesting. There's a lot of speculation about why they have not had as much of an impact, as certainly on a different scale than what we've seen in the United States. And there's been some speculation about potential cross immunity to other coronaviruses that may be playing a role. So again, just to sort of rehash the initial Kenya situation and its direct effects, again, they got an early mitigation and travel restrictions. And so pretty successful response initially. They shut down the country. There were certain counties you couldn't travel from one county to another. They were able to rapidly retool their regional HIV laboratories into COVID diagnostic centers, so that the same platform that's used for HIV viral load testing can be used for COVID testing. And so they were able to take those labs and retool them fairly quickly, actually, to be COVID diagnostic centers. They took some of the global fund money that's usually dedicated toward HIV and TB and malaria and redirected it towards COVID. And at a more local level, the Moy Teaching and Referral Hospital, which is the hospital we work with, developed a COVID task force and prepared and training and established a home-based care effort. But again, that's only sort of part of the story. So imagine trying to, socially, physically distance or keep yourself away from coronavirus when you live in a place like this, or you get your water from a place like this, or you ride in a bus to work like this, or in fact, you work in a hospital, or you are a patient in a hospital like this, right? So there's obviously no ability here for infection control and to keep yourself distanced from either colleagues or as a patient from other patients. And so, the limitations of the context and the setting sort of caught up. So while things looked good in the beginning, ultimately we suffered significant shortages in testing commodities, inadequate supplies of PPE. There was a lack of dedicated inpatient and ICU space as the numbers started to go up. Access to oxygen was a real problem. As you can see from those pictures, infection control is really lacking. And so there were a number of healthcare workers, actually over 35 deaths in Kenya of physicians alone, and probably more nurses. And unfortunately, the private medical insurers declared COVID an exclusion from all of their policies. They had a little clause on the bottom that said, the pandemic, you're not covered. And so people were sort of scrambling when even the healthcare workers themselves, the doctors, our colleagues, had no way to have health insurance if they got sick and they needed to be admitted to the hospital. Okay, so again, what have we done? So in terms of our health system strengthening, we provided some material goods. So we actually got access to some PPE. We got some testing commodities in terms of nasal swabs and clinical equipment, pulse oximeters. We got ultraviolet machines for decontamination of N95 masks. And we were able to get all that over to Kenya. There was a lot of workforce support. So IU faculty and other members of our consortium sharing their knowledge and their training through Zoom meetings like this one. And then doing some work to try and understand and mitigate the impact on service delivery of our core, clinical services that we're delivering in HIV and chronic diseases, oncology, and other areas. And then more at a community level, trying to understand and respond to the economic needs. And I'll talk a little bit about that too, but we've actually done some cash transfers to patients that are particularly vulnerable. So all of this has required, redirecting existing programmatic and philanthropic funds and an increased development effort to raise philanthropic funds, because that's a big way of how our program is funded. So our development and communications teams have really been hard at work and created virtual forums for connecting with program supporters and doing everything they can to raise the funds needed. So unfortunately, the worst may still be to come. Perhaps more devastating than the direct effects of COVID are the anticipated indirect effects of the pandemic. So this is a study from Lancet Global Health, and they have modeled out the impact of the COVID pandemic on deaths due to HIV, TB, and malaria over the next 5 years, and suggest that there could be an increase of 10% for HIV, 20% for tuberculosis, and 36% increase in deaths from malaria over the next 5 years, compared to if there was no COVID pandemic. And this is obviously mediated by interruption of antiretroviral therapy for HIV, delays in TB diagnosis and treatment initiation, and interrupted public health campaigns such as BedNet distribution. So that's obviously a harbinger of worse things to come. And it's not just infectious disease, it's really all essential services. So routine immunization programs have been disrupted. Non-communicable diseases, family planning and contraception, antenatal care, treatment of mental health disorders, all of these things have interruptions in supply chain and staff redeployment, insufficient PPE has resulted in closing of health facilities and financial difficulties that have set things back significantly in terms of the health sector. Add on to that the potential impact on economic development. So preliminary estimates are that COVID-19 will result in somewhere between 1.4 and 8% contraction in African economies, resulting in probably 30 million more people falling into poverty, and the number of acutely food insecure people could significantly increase. So this is going to really require an expansion of social welfare systems on a scale that we really haven't seen before. In terms of our own program, we've done a little bit of looking at this. We did a survey of one of our research cohorts, just a phone survey looking at the actual impact of the pandemic on health. Very few people, if any, had actually, even if they had symptoms consistent with COVID, had actually accessed COVID testing. So that's consistent with what we suggested before, which was a significant underrepresentation of the number of cases. Fortunately, in our HIV cohort, it looks like HIV treatment access and adherence was largely maintained. But about a third of patients experienced worsening depression or anxiety. So the mental health impacts were significant. And if we look at the economic impact, over 50% lost income, 13% lost their jobs, and 60% reported food insecurity most or some of the time. So again, economic impact is going to be with us for a long time to come. And unfortunately, the impacts are severe. So, all right, I'm going to switch gears now a little bit. Talk a little bit about applying our global experience to local COVID response in Indiana. So last June, the Center for Global Health was asked to assist with Indiana University's COVID response as part of a medical response team. And I think as many of you know, Indiana University has 9 campuses across the state, plus another several medical centers, and in total, probably about 120,000 faculty, staff, and students, constituents. So you might ask, well, why on earth would the Center for Global Health be asked to respond to the COVID response in Indiana? Well, in many ways, this goes back to our AMPATH experience. Our AMPATH response to the HIV pandemic started back in 2001 when the first patient was treated. By 2004, the US government launched the PEPFAR program, the President's Emergency Plan for AIDS Relief. Within a couple of years, we were now serving 20,000 people living with HIV. And as I said, currently we have 175,000 people living with HIV that are active in care within the AMPATH supported Ministry of Health program. This is all a public sector program. So how did we do that? Well, there were several steps to establishing the response to the HIV pandemic. We had to hire, train, mentor workforce. We had, had to train counselors and testers for opt-in testing, opt-out testing. Had to train care providers. Had to participate in prevention activities, write care protocols, address food insecurity, identify key populations, establish supply chains, building electronic medical record systems, contact tracing for HIV. Of course, working with the Ministry of Health and local health officials, and importantly, advocacy. So any of that sound familiar? Well, it's similar, right? So obviously the transmission dynamics are obviously very different for HIV and for COVID, but in many ways, the response parallels the pandemic response that we had to HIV. So prevention, mitigation, distancing, masks, shutdown, testing, of course, hugely important, both symptomatic testing and asymptomatic testing or surveillance testing. Contact tracing to support effective isolation and quarantine. coordinating our efforts with local health departments and the state Department of Health, and then identifying high-risk groups and responding to outbreaks. So at Indiana University sort of established, as I said, this medical response team, and it really had, I won't go into all these details, but really sort of 3 or 4 pillars. And we established this command structure, if you will, at each of the campuses, and a COVID response unit. That's what CRU stands for. And ultimately had these sort of 4 buckets in which our activities fell in. So symptomatic testing and mitigation strategies were in place. So we had people wearing masks and people socially distanced. We dramatically reduced the density of dormitories and classrooms. We had a partnership with Indiana University Health for symptomatic testing, where they would collect samples at various locations. We had to identify hire individuals to collect samples and operationalize quarantine and isolation space for residential campuses, and identify the high-risk groups. On the contact tracing side, we had to hire and train a workforce of program managers and contact tracers. So we have a first-tier contact tracing effort at Indiana University, and that's where the Center for Global Health has put a lot of our efforts. And I think it's important to understand that Indiana ranks, I think, 47th in regard to public health infrastructure and funding. So we recognized early on that we had the ability, if we did this at a university level, to take advantage of some of the existing knowledge that we have about students, faculty, and staff that the state would never necessarily know, right? So we know at the university level which dormitory someone lives in, we know who their roommate is, and we know who lives down the hall, and we know which activity they're in, or which sports team they're on, or which gym they go to. And so those are information that we could take advantage of in terms of tracking and responding to this epidemic, that we could really best implement at a university level. So we established MOUs with local health departments, we continue to have a daily review of outbreak investigation and cases, established consequences for noncompliance with procedures, and over the last few months have scaled up a massive sample collection and laboratory testing infrastructure. In fact, we've now established 3 laboratories at Indiana University that are serving the student, faculty, and staff population, doing very regular testing. And there are consequences to non-compliance with that. And of course, in terms of the vaccine, everything is being directed by the state, but we're working closely with them to try and provide volunteers. I think there are more than 400 or 500 medical students that are supporting local health department efforts to administer vaccine, and liaising again with establishing pods that might serve beyond, that will serve beyond Indiana University and serving some of the community. Most importantly is probably communications. We've had a robust communication strategy for both the internal IU population and also externally. We've had a team of people. Obviously, this is a big team of people that are conducting this, but we've been following a lot of metrics and positivity rates across the various testing strategies. We've had to monitor our lab test turnaround time, of course, and the efficiency of contact tracing, the utilization of quarantine and isolation. So we've looked at really about 16 different metrics that we're following on a daily basis to try and adjust our COVID response to the various things that we're seeing happening. So overall, really since July of last year, we've had more than 11,000 confirmed cases among the Indiana University constituents, and we've conducted over 10,000 close contact interviews. But the good news is there's really been no evidence of widespread classroom transmission. In fact, when we looked at this, there was no increased risk from in-class learning compared to those that were doing virtual learning. And the bottom line is that being part of the IU community has really been safer than not being part of the IU community because of the testing that was happening and the rapid response in which we were able to isolate and quarantine individuals. So these are the results of our mitigation testing over time. You can see in the fall, when the campus first opened, we had a significant bump in the rate. But really since then, it's really hovered in a pretty acceptable rate from a surveillance perspective. And in terms of our own metrics, in terms of contact tracing, we've been very pleased with these. So our success rate is very high, and our efficiency, we're actually reaching positive cases within 1 hour of their test coming into the system. We've actually completed the interview. And so we're very rapidly being able to isolate and quarantine folks that need to be. If you're interested, there was a recent article in the Atlantic that was published just a couple of days ago that actually describes the Indiana University response. Okay, so beyond that, the Center for Global Health has really played a significant advocacy role. So I'm advocating for the importance of the World Health Organization and our participation in it. Really, obviously, being advocates for global vaccine equity, and I think importantly, the focus on inequalities both in the U.S. and globally. So as you all know, there have been racial disparities in COVID incidence, outcomes, and vaccine rates. And it's interesting when you look at the global disparities and local disparities. If you look at the HIV map of the world, you can pretty easily see here on your left where the worst hit parts of the world are in terms of HIV. But if you look at the map on your right in COVID-19, the whole thing's sort of colored, right? So you have to look a little bit deeper to find the inequalities, but they're there. So this is a map of the sort of the degree of inequality in different countries. And the world over, really, COVID-19 has disproportionately affected the poor, minorities, and other vulnerable and marginalized populations. So this is just one article that highlighted this and went through some of the factors that are driving that. Mostly social determinants of health and higher rates of chronic disease, malnutrition, and poverty, lack of access to care, but also things like housing density and people that are working in manual labor jobs that can't, work from home and just work on Zoom. So rest assured, there is hope for the future. We've had, rapid vaccine development, as I mentioned earlier, in record time. And Gavi, which is the Global Alliance for Vaccines and Immunization, has set up this COVAX advanced market commitment that aims to ensure that 92 low and middle income countries have equitable access to COVID-19 vaccines. We're not there yet. They're dramatically underfunded in terms of that effort, but we're moving in the right direction. So maybe just to end here, sort of reflect a little bit on the opportunities and responsibility of the global health community. So, I think we all have a responsibility to assess and document the impact of COVID-19 on health programming, even as we strive to limit its damage. We have to acknowledge and document global inequalities and work to correct the underlying injustices that drive them. We've got to, as I said, continue to advocate for equitable access to diagnostics, therapeutics, and vaccines. But this is also an opportunity to develop new innovative ways of delivering care, telemedicine, new models of service delivery, mental health response with community health volunteers providing psychological first aid. I think, as we've pointed out, the number of the mental health impacts of this are significant, not just in Kenya, but in the United States as well. And we've seen it even amongst our student populations. When you ask people to stay inside and socially isolate, that's it can make things worse from a mental health perspective. And then obviously developing new models of engaging trainees in global health programming. When you can't travel, then you've got to think of other ways to educate people. So I think in summary, AMPATH's model provides a framework for global health partnerships that strive towards equity. And I think that we've fared fairly well in terms of some of these things, and in part because we have a program that's really longstanding and committed to some key principles. So Kenyan leadership. So while we've had North American presence in Kenya for a number of years, we've always been led by our Kenyans and are working to support the Kenyan infrastructure and Kenyan leaders. Individual and institutional capacity development and building public sector systems, not just silos. So while certainly there have been silos in global health with regards to the HIV and the response to the HIV pandemic, we've been trying to build the entire system in a sustainable way. Bilateral exchange, Kenyan Student Scholarship, reciprocal innovation are all really concepts that I think define AMPATH and have again put us in a fairly good position in terms of the impact of the pandemic. But it's also given us an opportunity to reflect upon the 30 years of partnership, and particularly in the context of new calls for this sort of concept of decolonization of global health, and think about, are we doing things well? Could we be doing things better? So again, we've adapted to the global pandemic. Challenges that lie ahead are significant, but so are the opportunities to make a difference. So I will pause there, and thank you very much again for the opportunity to speak tonight. And you can see those are my access websites and email address there. If anyone has questions.
Hey, thank you, Dr. Gardner. This is a very informative talk, and I'm sure I know we have a lot of questions here. If you have a question, you can go to the chat at the bottom of your screen and type in your question. And if you would like to ask the question, you can just type in, I'd prefer to ask the question myself, and I will call on you and you can unmute yourself and ask the question at the time. But we could start with a couple of questions. First of all, a couple of people have asked about the access to your slides. Would those be available to folks?
Sure, I can make those available, yeah.
Okay, we'll maybe, how would we do that if you could maybe send us a link, send it to Betty.
Yeah, I could
And then-
email it to you, yeah.
Yeah, okay, that'd be great. I can get those out to folks. So Larry Cimino had a question about making vaccines available. Larry, you there?
I am. Yes. Yeah. I was just curious. You mentioned the global program, and that's sort of what I was getting at. Do we really have commitment from the producing companies, from the countries where they're produced, to provide these to low and middle income countries around the world, like Kenya and others? And what happens in the first world when the low and middle income countries don't get vaccinated appropriately? And what do we have to worry about, as opposed to we want them all ourselves, which is sort of the general feeling around the world, I think, in the countries where they're prominent.
Right. Yeah, great questions. I mean, so again, this is not the time to be isolationist, right? This is the evidence that we're all connected, and something can, happen in a market or wherever it happened in China, and all of a sudden, throughout the world, we're all in a different state of life, right? And so we have to take this as a global community. And, there are significant challenges with regards to the first vaccines that have been approved in the United States. Obviously, the messenger RNA technology is amazing. It's a new, it's a fairly new, well, it's been worked on for a number of years, but it's a fairly new implementation of it. And it has some limitations, right? It has some advantages in the sense that it's fairly easy to produce one that can address the variant strains. But it requires a significant cold chain. We're talking about -90 freezers, and so it's not the easiest thing to deliver on the back of a bike out into a rural community in India or Kenya, and so it's probably not going to be the vaccine, frankly, that is made available to some parts of the world where refrigeration and freezers like that are just not available. So we're going to have to rely on these other vaccines that are either now approved, like the AstraZeneca Oxford vaccine, or hopefully the Johnson & Johnson vaccine, which hopefully will be approved fairly soon, which is nice because it's only a single shot as well. And those require, they're significantly easier in terms of getting out to rural areas and don't require the same level of refrigeration and things. So, I mean, I think, are we there yet in terms of our global commitment to global vaccine access? I think the answer is no. At least people are talking about it, and at least people are doing it. But I think, the reality is we're not there yet. So I think we need to continue to be loud voices and advocate for it. And frankly, there's no reason some of these companies couldn't give up some of their rights to it. I mean, they've really done, a lot of this with public funding. And just from a purely sort of efficacy standpoint, there's no point in being isolationist at this point, right? Like we are connected. We have global travel, and we've got to make it available.
And Russia and China are also developing their own, and I presume they're going to be doing some vaccine diplomacy with theirs as well. So
I suspect that's right. Yep. And they've been actually using theirs, and China and their military use their vaccine even before trials were conducted. So.
All right. Brought up China. There was a question about China. Actually, it's kind of a twofold question. First part was, could China have done a better job in avoiding the spread of the virus around the world? And secondly, did they influence the WHO in terms of their ability to manage that breakout?
Yeah, these are controversial questions, and I don't have tremendous insight into, but I think that there are I mean, on some level, it's hard to know exactly, right? Because we don't know exactly where this started, and we don't know, there wasn't a lot of transparency in the early days about what was happening. Would it have been any different if it been anywhere else? Not so sure. So, I think it's easy to point fingers, but I'm not so sure we wouldn't have done, same thing. The response of the WHO, I think, clearly we were underprepared as a global community for this pandemic. And if you look back through the literature, there are editorials from Bill Gates in 2015 and 2018 after the Ebola epidemic, talking about everything that we needed to put in place in terms of to be prepared for a global pandemic, and we just didn't do it. And our history as a world is not very good on this. We sort of remember things for about 18 months. There's some political will, and then it's like, well, it probably won't happen for a while again. And so we sort of just ration things down and kind of let it go. And there are obviously there's important things we need to put in place. We need surveillance systems. We need laboratories. We need rapid mobilization of teams. We need some to be able to transcend some of these regulatory barriers to diagnostics testing and vaccine and therapeutic testing. But we also need to invest in just good old primary healthcare infrastructure. I mean, if you look at the Ebola epidemic, even when healthcare was available, people didn't trust the system. And places like rural Western Kenya, in many places, you go to a health center and there are no staff and there are no drugs. And you ask someone to buy health insurance and utilize that as their primary healthcare infrastructure, but they're not going to trust it if there's no service delivery there, right? And so I think if we're really going to build, the trust is a really an important element of the health system, and community interaction. And if we're going to expect people to seek help, which is really the only opportunity we have to sort of find out what's happening from a surveillance or from an early diagnostic, point of view, then you have to build trust in the system. So, I think, again, not to be self-serving, but I think the types of long-term partnerships that we have at Indiana University and AMPATH are really the kinds of things that help, over generations build that kind of capacity at a primary healthcare level. Not that we've built, pandemic response laboratories and things. There's a certain amount of, siloed, specific response to infectious disease epidemics. But I think some of the primary healthcare infrastructure has been of the kind that we supported.
All right, Betty had a question.
Thank you, Ray. One's seeking a clarification, and the second one is a question. I'm seeking a clarification. I was communicating with another member of the committee. I missed. Did you say, Dr. Gardner, that the vaccines from Russia and China, they were releasing them before they went through proper clinical studies, a full run of it? And then the second is, I'll ask about public health. That's just a clarification.
They did. Yeah, so they actually utilized them in their own military and in their own populations before they actually had conducted large clinical trials of the sort that we required. Okay. Again, that was a decision that their governments made in terms of the rapidity with which they needed to sort of roll them out.
That's what you said. My question is about public health. In the United States, we have not paid much attention to public health, despite we know that public health has had such a contributing factor to increasing our longevity here in the United States through water, things like that. So do you think that what the United States has experienced, and traumatic as it is, will sufficiently and significantly change the right attitudes of people to pay more attention, to put more money into, more focus on public health from the top on down to the community level?
I can hope so, but I'm not supremely confident that will be. And in part because we have a system that's the incentives are aligned in different ways. We really have a health system that is very focused on curative medicine and technology and response to illness. And those aren't necessarily bad things, but they're they come at an expense, and they come at an expense of sort of some of the preventative and sort of more, community-based care that we provide. So go ahead, sorry.
Would it be cynical then to suggest that perhaps there's more money in people being sick than in staying well because of public health?
I know, I think cynical as it might be, I think it's accurate. I mean, even as I reflect on our own, training in medical school, I mean, it's very easy to convince yourself as a young doctor or an older doctor, frankly, working in our health systems these days, you can keep yourself very busy with patients coming to you. And because we're constantly accessing technology and laboratory testing and doing more testing and responding to this therapeutic and trialing this, but you can miss the boat, right? I mean, you can miss the problem is that this person doesn't have food, or the problem is that they, have to work in a setting that's making them sick, or, some of these things of drinking water that's not safe, right? So some of these social determinants are far more powerful than some of these, more sort of biological determinants of health, if you will. Not that they're not important, of course, they're all important, but I think we do a better job of addressing those biological ones than we do of those social determinants. And they have probably a bigger impact, frankly, at the end of the day. You look at nutrition and, obesity rates and, other public health.
So we had a question here from Meghna. Are there any interaction complications that have arisen with the COVID vaccine and those who are being treated with antiretroviral therapy?
Yeah, good question. Well, to be honest, we don't have that much experience yet with the vaccine in patients with immunocompromised conditions like HIV, because many states in the United States that have rolled out the vaccine have started appropriately enough with older populations that are at higher risk for poor outcomes, so higher risk of morbidity and mortality. And so while there's certainly a fraction of older patients that are infected with HIV, that's not where the bulk of the HIV epidemic is. So in places like Kenya, we really haven't rolled out the vaccine yet. In terms of the impact of COVID and HIV, it's been a little of a mixed bag, but we haven't seen tremendously increased rates of COVID or poor outcomes in patients with HIV. But obviously, they're concerned that patients, not just with HIV, but other immunocompromising conditions, cancers, cancer therapies, immunological therapies, that those patients may be at higher risk for poor outcomes. And so I suspect what we'll see is, very shortly, particularly in Indiana, I think the next group of patients, when we reach about, the 60 age threshold, which I hear may be coming as early as, next week, starting to enroll people. Maybe some variation of the population with immunocompromised conditions. So whether it's transplant patients that are on immunosuppressive drugs, or patients that are otherwise immunocompromised, will likely be one of the next cohorts to get it. These have been difficult decisions to make for various states and ethics panels and things about who, where do you get the most bang for your buck in terms of the vaccine. Obviously, you have to think of patients that are suffering the most, but you also have to think of people that are spreading it the most. So in some cases those directly conflict one another. If you've got young people running around and they're the ones spreading it to everybody, then maybe it makes sense to vaccinate some of those folks so that they're not spreading it. Of course, we still are lacking some of that data to demonstrate the impact of vaccine on transmission. So right now, what we know is the vaccine is very effective at preventing serious consequences of the COVID infection. But we're still waiting for data to demonstrate that it actually stops or significantly decreases transmission, because it's theoretically possible that someone could be still shedding the virus. They could actually have asymptomatic infection, not get terribly sick, but still be shedding it and transmit to someone who doesn't have the illness. So we should have that data from the early clinical trials over the next month or two. I would think we'd have a pretty good sense of that. And we may get it from places like Israel that are now vaccinating, large portions of their population and seeing rates go down dramatically.
All right, thank you. Bruce Frank has given me about 15 questions. I'm going to call on him and let him pick his favorite question, which one he wants, the one question he really must have answered.
Oh, shoot. That's impossible, right? Thanks for the presentation. We have an international problem now. And I don't see how, or I would like to know your opinion as to how to manage it internationally.
Mm.
And the WHO, part of the United Nations, is the tool in place right now. We have half the United States are thinking that it's an ineffective organization.
Mhm.
And we have data that, as you just said, it's controversial about their performance of mitigating the spread of the disease initially. What's going to happen in 2 years? How does the world manage this such that we don't go through this again?
Right.
I'm running out of time.
Yeah, no, an excellent question, and obviously no easy answers. I think that there's been discussion about WHO reform for many, many years, and the question is,
Reform it right now for us. Tell us what you would like to see.
well, I think they've got a bit of a bum rap in the sense that there was there may. It's hard to know how much of a sort of biased response or how much influence went into it, but they have at least taken global leadership and put some flags in the ground in terms of what needs to be done. I think that the WHO doesn't have the resources, frankly, to be able to mobilize what the global response that we needed. So they're really a policy sort of guidance body, but it's going to take. I heard one faculty from Mount Sinai the other day suggesting that maybe we need these corporations, some of these corporations that have frankly done very well in this pandemic, the Amazons of the world, maybe need to put money up to support sort of a global response, and support some of the infrastructures that we're going to need. That again, people like Bill Gates and others have sort of very clearly delineated. But it's going to require, I think the most challenging thing is really that, as you alluded to, this sort of, we lack a sense of global cooperation. And frankly, we lack a sense of national collaboration right now. We're more divided than almost any time in our history.
Careful, we fought a civil war once.
Well, that's true. But, I think that how you overcome those differences in perspectives, I think hard to know.
Okay, will this happen again in 2 years then?
Well, certainly the rate at which we've seen pandemics has increased. So over the last 20 years, we've seen a number of different coronavirus in particular, but pandemic influenza, other diseases can certainly happen again. So we better take heed and learn our lesson from this and develop some sort of response, even if it's not the optimal response.
What is going on in China that it seems to come out of China regularly?
Well, there's a number of, I think there are a number of factors, where there are natural mutations that are happening all the time, right? In these viruses in particular. So where there is interaction between animals and humans, then these things have the opportunity to, once a mutation occurs, it can jump and all of a sudden it has a survival advantage or a transmission advantage in some other species. So some of that is probably, frankly, dictated by climate change and we're moving into environments where humans haven't been before and where animals were, and some of it relates to sort of just more dense interactions with species like pigs and birds, that where mutations happen fairly rapidly and can lead to this sort of jumping in species and become sort of a global pandemic. But viruses like the flu.
You've gotten more than one question in.
I was going to say, you have to mute me, right?
Judy had a question. Is AMPATH able to focus on public health differently than in the US? you know, she said that healthy eating was part of AMPATH at the beginning, she seemed to remember.
We did. So in the HIV response, nutrition was a hugely important part of our initial response. So what was very obvious from the beginning was that even when we had access to antiretroviral therapy through the support of the US government through PEPFAR, we would see patients in clinic and offer them drugs, but they wouldn't take them because they would make their stomachs upset and they didn't have food. And if they didn't have any food, they didn't want to take their medicines. So one of the things that AMPATH did early on was to create partnerships with the World Food Program. We actually, for a number of years, had these high production farms where we would grow vegetables and supplement the sort of oil and beans that would come from the World Food Program. We actually at one point had one of the largest, medically associated feeding programs in the world. And the combination of these two things, and then it was, again, you sort of see how these things evolve. The initial food prescription program was, well, you can only give it to the patient. Right, so now you can only give the food to the patient. So now you've got a mother of 3 coming in to pick up the antiretrovirals and the food, and you're telling her she can't share it with her children. Well, good luck. Right. So then we sort of evolved and said, okay, well, obviously you need to be able to treat, give enough food to feed the family. And so that was a hugely important part, and not just from a sort of palatable perspective from the medications, but obviously the nutrition and the malnourishment that people had going into it, and the sort of wasting syndromes that people with HIV had, required that level of response in order to restore immunity, because the drugs wouldn't work necessarily if you didn't have any food. So, has AMPATH, I think, taken on a different approach? I think there is, working in places where the resources are more limited is obviously challenging, but I think it does create more opportunities as well. So there's something about the adversity and the lack of systems that allows a creativity of thinking that sometimes can be very, very useful. And in fact, this is part of what we mean when we say reciprocal innovation is in these partnerships that we've established, is this concept that not only do we have things we've learned over here that we can apply in Kenya, but we actually have lessons learned in Kenya that we can apply here. And we have a number of different examples of that in our programming domestically. So some of you may be familiar with a program called the We Care program that has taken really lessons learned from Kenya using community health volunteers and partnering them with women at high risk for poor pregnancy outcomes, particularly African-American women and minority populations, and help them navigate the system here in the United States and sort of be a accompaniment through the system in a way that's resulted in lower rates of maternal mortality and lower rates of infant mortality. And it was really sort of lessons learned in resource limited settings that can be applied here. So I do think there is, from a purely utilitarian perspective, investing in global health systems, lessons to be learned that we can take advantage of here as well. And there's sort of less, there's sort of less regulatory barriers. When you've got the system we're working in Kenya, there's not as many fiefdoms. Here, I used to joke where I did some of my training in Boston, depending on which corner of the park you fell in, you were taken to a different hospital. So Boston Medical Center, Mass General, Brigham Women's, Beth Israel. If you were sort of a drunk and you fell over, you got the same exact workup. CAT scan of your head, heart, echocardiogram, EKGs, because none of the systems talk to each other, right? They all had standalone systems, never talking to each other. And that's probably not the most efficient use of resources, to understate it. But so in places where you don't have those sort of fiefdoms and those systems built up, there's sometimes going to be more creative solutions that you develop.
So how effective are these other organizations, Doctors Without Borders, and I've been involved with Rotary doing polio vaccinations, and the Gates Foundation, and how do they conflict with governments? Do they aid governments? What is the kind of the role of those NGOs in?
Yeah, that's a good question. So I think I would say they all serve really critical roles. So MSF, for instance, has the ability to very rapidly deploy providers in settings where you don't have time to build systems. So I think they serve a critical role. And in fact, in Western Kenya, before HIV, before the AMPATH response took place, there were several locations where MSF had very rapidly deployed healthcare providers with medications and with the tools necessary to sort of, the idea is sort of stand up a clinic in a day or stand up a clinic, very, very quickly. But there are limitations to that, right? So that those are not health systems, those are not public sector systems, they're not sustainable in the long run. And so you really do need both. I think, the Gates Foundation has, done a tremendous amount to support therapeutics and diagnostics, and made sort of tried to make investments in a lot of things that are sort of game changer, the kind of the diagnostic box, that's simple but can do it all kind of thing, so that can be taken out into the rural communities and improve access to certain care. So I think each of these organizations plays an important role, but they're complementary, and they're not a replacement for one another. I mean, USAID is another example. USAID has done tremendous amount of work. PEPFAR is arguably one of the most successful global health programs ever, supporting really a global response to the HIV pandemic. So they're not. It's not a one or the other.
Mhm. So one of I mentioned Rotary, and I know that one of the issues that comes up sometimes is reluctance to get vaccines because of religious fears and cultural issues and so forth. How much of a problem will that be in terms of the vaccine for COVID?
Well, it could be a significant problem. So, the latest estimates are that we probably need somewhere around 80, maybe 85%, vaccine coverage before we achieve herd immunity, where we start to see, dramatic drop-offs. Of course, these are, theoretical models. We don't really know the answer yet, but based on our prior experience, it looks like we might need to achieve rates as high as that before we bring this virus to its knees. That's not going to be easy to achieve. Right now, we're if you look at surveys, we're somewhere in the order of 2/3 of healthcare workers are getting vaccinated. So that even among, people that are working with these, seeing the direct impact of this, presumably understand the science and want to protect themselves, are not reaching 80% levels. And certainly in general populations, we're seeing probably even slightly lower than that. Now, I do think as more and more people, see the impact, and there's been a lot of sort of reticence to be one of the first ones to get the vaccine. So more and more people get it and are, confident that the vaccine is not going to have negative consequences, then I think more people will come forward to get it. But we've got to do some pretty, significant heavy lifting to convince, particularly, communities of color who maybe don't have as much confidence or trust in the system, to be vaccinated. And so that's going to take a real concerted effort, mobilizing, religious leaders and others who are trusted members of these communities, to convince people that it's worth coming forward for the vaccine. And we're going to need that. Again, you can't just protect yourself and pretend this is going to go away. It's going to have to be a global effort.
Mm-hmm.
And combating, I should say, combating misinformation is obviously a huge component of that. So, not just obviously here in the United States, we've had a tremendous amount of that, but in places like Kenya as well, there are, constantly rumors flying around on social media and WhatsApp and things. And, we've got to have trusted voices that can, speak to the science and take advantage of a trusted brand, if you will, to try and communicate what's true.
Are there any lessons to be learned from our work in Africa during the AIDS crisis in the aughts, in 2004, 2005, under George Bush's administration?
Yeah, absolutely. I mean, in many ways, what I've described is the PEPFAR response is that program that George Bush launched in 2004. So AMPATH started its HIV treatment program in 2001, but it really was when PEPFAR kicked in. Of course, we had this long-term institutional and individual relationships that allowed us to rapidly scale up our support for patients in Western Kenya. But it really was hugely important to have that support from the U.S. government to respond to that pandemic. And I think, as I've tried to demonstrate, a lot of the same sort of principles and approaches to systems strengthening can serve us not just in it is a global pandemic, right? The HIV epidemic is a global pandemic as well. Again, the transmission dynamics are obviously pretty dramatically different. It's not something you get from breathing air and from being within 6 feet of one another, but so it requires a different type of response. But yeah, absolutely. I think there are parallels in the response that are very obvious.
Okay. Well, I think those are all the questions we have at this point. Does either Larry or Betty want to kind of close us out here?
Yes, thank you, Ray. I want to thank you again. Thank you, Dr. Gardner. That was fantastic. It was very interesting. We look forward to seeing the slides, please, if we may. There are a lot of them, and I thought, oh gosh, Don, I wanted to see that. So I look forward to that. And you can send it to me, and then we will see the best way to get it out to people who attended this evening. And I want to remind everybody that next week we meet again by Zoom, and we will have Dr. Didier Gondola, who will be talking about China and Africa. And that should be a really interesting program. We will then have a 2-week break where that third week in February will be a distinguished speakers program. And then we will come back again on the 23rd, where we'll be talking about global supply chains and national security. Larry, will you tell us, please, who our speaker is going to be for distinguished speakers the week of whatever that date is?
Yes, it's the third Thursday of the month. Dr. Ian McIntosh, who is an Australian anthropologist and peace advocate, is going to do a very interesting program on the role of pilgrimage around the world, pilgrimage and international diplomacy. He's going to talk about things that he first learned traveling with the Aborigines in Australia, but then went on to study pilgrimage in all its manifestations around the world, and drew some very interesting conclusions about the role that pilgrimage can play in bringing people together, working for peace, and how you can apply the ideals of pilgrimage in other group activities. I think it's going to be a fascinating program, and I look forward to seeing people for that program.
It will be fascinating. Thank you, Larry. Dr. McIntosh is a member of our board. We typically have as our speakers people we go far and wide, and now with Zoom we can go really wide. One of our speakers for Great Decisions is from Ireland with United Nations for many years, an incredible professional background, still does a lot of groups, and he's going to be talking about globalization. But Dr. McIntosh is a member of our board, and he talked about one evening before our board meeting about the work he was doing. And really, we could have just done away with the board meeting and let him talk the rest of the time. We were so fascinated, so we thought, well, we got to bring him back. So thank you, everyone. And thank you for coming. We really enjoyed this Zoom presence. If we were in the room, we'd be all hanging around to talk with the speaker afterward. I think we're just going to, I will tell you that we have something very exciting though in mind with Great Decisions this year, that we are going to be having a couple of interesting twists on the Great Decision program that is going to be involving, what did we call it? Someone from the committee helped me. Nightcap, wasn't it? We're going to be doing something later on when the season ends, where we're going to be doing a extended thing where we have a chat, but I think for a couple of our sessions coming up, and we'll tell you what they are, where we are actually going to think, well, let's just maybe people would like to hang out a little bit. And when the program officially ends, I wish I could remember, can you tell me anybody, one is Dr. Pierre Atlas, I know that. Oh, I know what it is, yes. It will be Dr. Pierre Atlas who will be speaking on March the 9th, and it'll also be our last one with Dr. John McCormick on the 20th of April. That will be literally when the program ends. We'll say, okay, for those of you who would like to go on, that's fine. The rest of you who'd like to stay and just hang out a little bit and have more of an informal chat, go grab your favorite beverage and come back. We'll be right here, and we're going to carry on. We think that's going to be really fun. So we've got a very exciting lineup of speakers. We're doing something a little different to keep you really interested and flowing with us. Thank you once again. I'm going to ask our technical host now if she could just please sign us off. Thank you all so much. You've been a wonderful audience.
Thank you.